Hello.
Yeah, Saurabhji, I'm trying to share the PPT. I'm just a minute. How do you share the PPT? I'm not sure. Can I mail you? Just a second.
Yes, madam.
Now you can see.
Yeah, madam, your screen is visible now.
Okay, okay. One second. Yeah, now shall we start?
Yes, madam. We can start, but you have to start with your introduction first.
Right, right. Yes. So, one second. Good afternoon, everyone. Today I'll be talking about recent advances in epilepsy. I'm Dr. Dhanashri. I'm a neurophysician. I'm working in Pune as a consultant neurologist. I've been working as a consultant neurologist since last 7 years, and I thank you all for giving me this opportunity to talk regarding this important topic. So let's proceed. So you see the etiology of what is epilepsy. First of all, epilepsy is any abnormal firing in the electrical firing in the brain, and if it happens repeatedly, it is called as epilepsy. And if it is and the one-time episode is called as a seizure. So these are the causes of epilepsy etiology, and you can see most of the time we are not able to find out the reason why this is happening to a particular patient. Almost 70 to, I would say, in fact, 80% of the cases are like undiagnosed. And remaining cases, you can see there are different kind of reasons. It can be infection, developmental, or it can be trauma to the brain, or even stroke can cause epilepsy. So, so this is regarding the epilepsy. Two, if you have two unprovoked seizures 24 hours apart, then the patient is been called as having seizures and a syndrome of epilepsy. And this is a classification of seizures: simple partial seizures and generalized seizures. In partial seizures, it can be simple, complex, or partial with secondary generalization. In generalized seizures, it can be absence, myoclonic. Absence means the patient will have a blank stare or unresponsiveness. Myoclonic means a jerky, abnormal jerky movement, which is irregular, not regular. If it is regular, we call it as a tremor. Or they can have clonic tonic seizures, and usually clonic movements are rhythmic, and they can have tonic clonic seizures or atonic seizures where patient usually falls down because of loss of balance, loss of posture. So two important mechanism, either excitation or inhibition. So either involvement of sodium invert sodium channel or calcium currents, or glutamate and aspartate neurotransmitter are involved in excitation. And in inhibition, if there is an abnormality with the outward potassium current or ionic invert chloride currents, or if there is an involvement of GABA neurotransmitter. So if there is an increased excitation or reduced inhibition, then it can cause an hyperexcitable state. You can see if there is an increased excited neurotransmitter glutamate, uh, then it can cause epilepsy. And if there is decreased GABA input, means which is an inhibitory neurotransmitter, then there is a hyperexcitability. Or if there is a problem with the channels, voltage-related ionic channels. So you can see initially, like from 1930s and 40s, we started getting medications for treating epilepsy. And initially, before that, phenobarbital was the primary drug which was used for treating epilepsy. It is still being used because it is very potent medication. But you can see the first generations are the commoner ones, like phenytoin, ethosuximide, and then other medications like primidone and all. And in second generation, these are the newer medication which are now commonly used, like levetiracetam, lacosamide, zonisamide, lamotrigine, oxcarbazepine, and all. So these are second generation medication which are being developed in last couple of decades. So, which are the drug of choice for these medications, these different kinds of epilepsies? For generalized seizures, definitely valproic acid is a drug of choice. Lamotrigine, it is very effective in generalized, but we have to be very cautious because of development of rashes. So, we have to introduce these medications slowly and gradually, and step up the dose gradually. And then alternatives are some other medications like phenytoin, carbamazepine, oxcarbazepine. For focal, these are again lamotrigine, carbamazepine, oxcarbazepine, levetiracetam, phenobarbital. So for atypical absence and atypical absence, valproic acid is a drug of choice, and lamotrigine also is preferred. Ethosuximide for typical absence seizures. And apart from that, alternatively, if the other primary first line medications are not working, we can use clonazepam and sometimes felbamate or clobazepam. So why do we need newer therapies? So we have so many medication right now. Then why do we need newer medications? Because some of these medication have interactions with each other. They interact with each other, or they interact with other medication. If suppose some patients are taking some medication from other ailments, medical ailments and problems, then they can interact with other medications. And if they have some side effects, especially dose limiting side effects, like beyond certain limits, beyond certain dosage, we cannot step up the dose, but the side effect keep happening. So in that case, it's a problem. Some medication require multiple daily dosing, so we want to avoid that. Then effect, some medication after few months or years, their effect usually reduces, and it effects wanes off. So for that, we need a newer medication which will keep working for years and years together, and patient doesn't have to change the medication because of lack of efficacy. And teratogenicity, this is very important thing, because if the patient is in a childbearing age, females of childbearing age, they are having epilepsy, then you have to think of this problem, because some medications are known to cause teratogenicity, and especially if they are given in a higher dosage, there is a high chance the child may have some birth defect. So we want to avoid that. So there are some new drugs which are targeting older targets, like older or sodium channels or calcium channels or neurotransmitters. So what are those medications? Like carbamazepine analogs. So carbamazepine are newer medication. Valproate analogs. So valnoctamide and valpromide is a newer analog. Then SV2A synaptic vesicle protein analogs, working on those proteins, like levetiracetam. These are breviracetam and selletracetam. So carbamates, there is a fluorofelbamate and fluorofelbamate and carisbamate. And another medication is stiripentol. So these are newer medication targeting the older uh, mechanism of action basically. So carbamazepine is widely used. Even in India, we use it quite often, especially those who are not tolerating carbamazepine or oxcarbazepine. This can be used, and this the biggest advantage is it is less neurotoxic than carbamazepine and oxcarbazepine, and also it doesn't undergo auto-induction. Means the effect usually lasts and it doesn't wears off. And the another advantage is we can give it once in a day. Sodium valproate analogs are valpromide and valnoctamide. So these medication usually these medications are being used in other countries and not in India, but are said to be very potent inhibitor of liver enzymes. So that's why are not very much preferred even in other countries, because if you have so much of inhibition of liver microenzymes, then they can have a lot of interactions with other medications. So this is again the same. This is under a phase 2 study. This was actually under phase 2 study and it's been under market. Carbamates, fluorofelbamate and casbamate, these are also being used in other countries, not in India yet, but they also have found that they are not very helpful or not very much superior than the previous medication called felbamate. Okay, so what is felbamate? This is again, it's working on sodium channels and all. But these felbamate is working on NMDA receptors also. It inhibits this excitatory neurotransmitter NMDA, and that's why it reduces the chance of having epilepsy. Only advantage of this is it lacks hepatotoxicity, but it's not being widely used because of lack of awareness, lack of results from various studies. So this is another medication, stilipentol. It increases the GABA release, which is an inhibitory neurotransmitter, and it is a potent inhibitor of these liver enzymes, UIP enzymes. So it can cause a lot of interactions, but it is approved for myoclonic epilepsy. And the dose is usually you start with 50 milligram and step up with 100 milligram per day. And it's not widely used in India, but other countries they are using it. Yes, brivaracetam is now probably, I would say, drug of choice in India. Whenever there is a new onset epilepsy or an epilepsy which is not responding to other medications, we can try this medication, and it works on SV2A protein, and it has another additional mechanism of action, like it works also by blocking sodium channel. And it is used for mainly partial seizures, but nowadays it can be used for even generalized epilepsy also with a great efficacy, and it has less side effect. The behavioral side effect which happens with the levetiracetam, like the important ones are suicidal tendencies, are not seen with the brivaracetam, and it also causes less sedation. So this is not been used in India, but outside countries, yes, this levetiracetam not very much widely been used because it's still under studies, and it is the mechanism of action is again same. It works on SV2A protein. Now these are some novel targets. So new targets. This is ganaxolone, which is like an hormonal analog. It's like a neurosteroid. This has been under study. Okay, this is under phase 3 trial. Then there's another one, losigamone. This is again another new molecule which is used for a which can be used for refractory seizure and is under phase 3 study. Then there is another medication called retigabine. So this is an inhibitor of voltage-gated potassium channel, and this is being used in some countries with some efficacy. And this is basically for it works on potassium channel, voltage-gated potassium channel, and it opens these channels and causes inhibition of this kind of inhibition on refractory state, repolarization state, and thus reduces the chance of having epilepsy. So this is a molecule nowadays being quite commonly used in India also, parampenil. It works on AMPA receptor and it is an antagonist of AMPA receptor. And if mostly it is used whenever there is an inefficacy or lack of efficacy because of other medication and refractory seizures are there. So you can try this medication. You start with 2 milligram and gradually step up the dose. Every week you increase by 2 milligram, and maximum you can give to 8 to 10 milligram. So this is now FDA approved, and we can use this medication. Then this is another medication. It is being studied in other countries. Caspase 1 inhibitor, belnacassan. So this is an inhibitor of interleukin converting enzyme, and basically it works in refractory epilepsy. So it depends, like depending on the result of the study, we can think about this medication as a potential drug of choice. Then there is another DPVPA, which is a phospholipid derivative of valproic acid. This is another medication under study, which is being studied by multiple centers, is under trial. Then another bumetanide. This is like a diuretic and being used in some studies, smaller studies, but not widely preferred. Then intranasal formulation, we are using it quite oftenly in India also. Some sprays, in the form of sprays, we use it. These midazolam sprays. So we can use them, especially whenever there is an ongoing seizure going on. So to avoid further seizures from happening, or to stop those seizures, ongoing seizures, you can use these midazolam sprays, intranasal formulations. And because the absorption happens very fast, the chances of preventing the seizures are very high with this medication. But it should be used as an emergency medication and not the regular one. So diazepam auto injections are there, especially those are having quite often and unpredictable seizures. But these are not being used and marketed in India yet. But yes, midazolam sprays are definitely, we are using it very often. Now these are some other drugs in pipeline, means they are under study, like becampanel, tarampanel, cellurampanel. These are like parampanel kind of medications which works on AMPA receptors, and other medication like they are working on potassium channel, and they are basically opener of potassium channel and creates a refractory state in the cell, and thus causes inhibition of the seizure. So there's another method to, so those patients who are not responding to any medication, and like if we are giving many multiple medications, then we can think of undergoing this process, which is called as vagal nerve stimulation. So we put a vagal nerve stimulator. It's like a pacemaker which is placed under the subcutaneous tissue, and it's a device which stimulates the vagus nerve and thus causes the inhibition of seizures. Okay, so especially we use it for partial and generalized refractory seizures, or Lennox-Gastaut syndrome, or patient who are poor candidate for surgeries. We can use this. The only important common side effect is usually patient can have hoarseness of voice or difficulty in swallowing, or they can have cough, and discomfort in the throat. Then there is another thing which is widely used in other countries. It's called deep brain stimulation. Here in India, we use this for Parkinson's kind of diseases, but in outside countries and in couple of centers in even in India also, this has been used for controlling the refractory seizures. And we usually the target is anterior thalamic nucleus, or the centromedian nucleus of the thalamus. By stimulating these nuclei, we inhibit the excitatory transmission. Now, if even if trying other things like these vagal nerve stimulation or deep brain stimulation and multiple medications, if the patient is not responding, then patient can be thought for an epilepsy surgery, or directly if patient is a good candidate and can have a good outcome without trying all these multiple medication or trying out these other modalities like vagal nerve stimulation or deep brain stimulation, we can think of epilepsy surgery straight away. So patients who are having persistent seizures and not responding to two medications, or it is causing impairment of the quality of life because of the seizures, then these are the candidates for epilepsy surgery. So what do you do for before thinking about taking the patient under knife? You take a proper history, you examine the patient, you rule out the other comorbidities, and you see the what kind of seizures patient is having. Then we do these scans, and with this scan we correlate the history and examination finding with the MRI finding, and of course with the video EEG finding. And if everything is fitting in together, and if the patient is a good surgical candidate, then we can think about uh, operating this patient for surgeries, epilepsy surgeries. So usually in EEGs, we like to have video EEGs so as to correlate the historical and examination finding with the electrographic findings. Okay, and with that we will confirm, okay, this is coming from this particular focus and this particular area of the brain, so that we are more sure before operating. So you can see here the right hippocampal sclerosis. The arrow shows there is a sclerosis, and that is the area of interest. So here, this is mesial temporal sclerosis. Left temporal bone is showing sclerosis. The arrow is showing the left temporal bone sclerosis. So we also ask patient to undergo these functional imaging in certain scenarios, like PET scan and SPECT scan, to rule out to confirm our findings which are seen on MRI and EEG. So we usually see hypometabolism interictally between the episodes, and ictally there will be in hyperperfusion. Okay, so we have to correlate all these findings. So neuropsychological testing, WADA testing, and magnetoencephalographic testing, these are some pre-surgical evaluation. So we have to, why do we do this? Because we want to estimate the chance of having morbidity or neurological deficit after the surgery, and we want to minimize as much as possible neuro deficit because of surgery. So we do these tests, basically WADA test is injection of amoebarbital in the carotid ipsilaterally, and see the effect of this injection on the language and memory, and then predicting the post-operative outcome. Then neuropsychological testing, there are a lot of batteries of tests available to understand the cognitive impairment which can happen after the surgery. Magnetoencephalography we usually not perform in all the patients, but in certain cases we can perform to understand the localization basically. So there are some intracranial EEG methods where these are used during the surgery, and grades and strips which are used commonly subdurally. Even parenchymal depth electrodes are used. Then for brain mapping to understand the focus, we use stimulation, SSEPs, functional MRIs, and magnetoencephalography, preoperatively and also sometimes during surgeries. So types of surgical procedure, either you resect the particular focus, or there are some palliative surgeries where you remove a part of a brain, like corpus callosectomy or hemispherectomy, These are some kind of a radical treatment where the chance of having seizure reduces significantly, but the deficit may be there. But it depends, like which side is involved and how much we are resecting and what kind of clinical situation is in that patient. These are some experimental surgical treatments, but these are now being used in many of the centers, like deep brain stimulation, gamma knife, some stimulation methods. So for mesial temporal lobe and non-mesial temporal surgeries, like if there is a glioma, you remove the glioma. If there is some malformation, vascular malformation, or there is some SOL, you try to remove that lesion. That is called lesionectomy. And if there is a mesial temporal sclerosis, you try to resect that area. Okay, lesionectomy, lobectomy. Then there are some procedures called disconnection syndromes. You create a disconnection between two hemispheres uh, giving insertion on the corpus callosum. Then there are hemispherectomy. Then for mesial sclerosis, temporal lobectomy and all. So these are some procedures. So you can see we are trying to localizing the lesion on one side, okay, and use the stereotactic methods, okay. So this is the upper scan shows the involvement of the brain, and the lower scan shows the resected area. This area is resected. Okay, this is an involved brain, and this area is resected, and which is basically removing the involved part of the brain to reduce the chance of epilepsy. So I think I've covered all the points, almost the recent things happening in epilepsy. So these are the most of the things which are happening in epilepsy. The newer medications, then the vagal nerve stimulation, deep brain stimulation, and some surgical procedures, stereotactic surgeries, and all. So I hope this was helpful. So if anyone is having questions, you can let me know.
Hello.
Yeah.
Yes, madam. You are done with the presentation?
Yes.
Yeah. So, madam, you can stop sharing your screen.
Okay.
Yeah, and there are some questions also.
Yes.
Yeah.
So the first question is, how is paroxysmal depolarization shift characterized in epileptic seizures? Okay. So basically, so I hope the question is basically they want to ask how it is clinically manifesting. So whenever there is a depolarization, whenever there is a depolarization of a particular cell, there will be spread of that activity, and there will be involvement of a particular area, and sometimes the complete brain, it spreads to other hemisphere, and then it can cause, depending on where is onset and where it spreads, it can cause a clinical seizure, and patient can have an seizure episode. It can be anything. It can be a motor or sensory episode, or it can be a focal or a generalized episode, or focal with secondary generalized episode.
Madam, there is one more question.
What is the role of gamma release in the pathophysiology of epileptic seizures? So GABA, basically, it's a neurotransmitter. GABA is a neurotransmitter, gamma aminobutyric acid. So, and it is an inhibitory neurotransmitter. So whenever, basically, whenever there is a release of GABA neurotransmitter, there will be an inhibition of the excitatory impulse. There will be mm, inhibition of ionic channels which are going to cause uh, epilepsy and excitation and epilepsy. So it's basically helpful in inhibition of the excitatory neurotransmission and or inhibition of ionic channels which are causative, play an important role in creating an seizure episode.
Yeah, madam, we have one more question.
Hmm.
Yeah.
How does the pathophysiology of focal onset epileptic seizures differ from generalized onset epileptic seizures? Okay. So basically, in focal onset, we have a particular area which is involved, and the onset is in a particular area, and then it may or may not spread to other areas, and it take usually there will be a lag and it takes some time, and so that we can appreciate there is the onset is focal by electrographically, by seeing the focus on the EEG in a particular area like frontal or temporal or any area, and clinically, having a particular area of the body involved. Pathophysiologically, of course, it is very difficult most of the times to differentiate if it is happening, because most of the time these impulses spread so fast, it might be very difficult to differentiate from a true focal seizure, true generalized seizure from a focal onset secondary generalized seizure. But yes, in generalized onset, usually the onset is in a particular, though it's in the particular area, but it's synchronous and it spreads very fast to other areas of the brain, so that it may not appear as a focal onset. But usually, and on even in on the electrography EEG, you see there will be a generalized discharges, and the onset is abrupt, and there will be an paroxysmal discharges, abrupt onset paroxysmal discharges happening synchronously on the EEGs.
Yeah, we have one more last question now.
Hmm. Does alteration of the normal state of the chloride channels affect the pathophysiology of epilepsy? Yes, it can affect the pathophysiology of epilepsy. Yes.
Hello. Yes, madam. We are done with all the questions.
Okay.
Yeah. Thank you very much, madam, for your valuable time and sharing the valuable insights.